I'm going to speak in English again, talking about today, again, about pediatrics, but this interesting area of cardiac markers in pediatrics. It's not well understood or appreciated that cardiac markers are actually used quite often in children's hospitals, more and more so in many areas of pediatric care. So I'm going to try to highlight this. This lecture is based on a review article we wrote in Clinical Chemistry. It was published last year, focusing on cardiac marker applications in pediatrics. Now, so today I'm going to give an overview of cardiac markers. I'm sure you're very familiar. Then I'm going to overview the evidence for cardiac marker measurement in pediatric clinical indications and for various cardiovascular conditions, including primary heart disease, but also heart failure and cardiac surgery and so on. And then overview the evidence also for secondary heart disease applications. Well, as you know, cardiac markers, there are several that are used in largely in adult hospitals, but more and more so in children hospitals. And it includes cardiac troponins. And there are different types of cardiac troponins as shown here. And can you see? You can see the my cursor here. So these are proteins, really important cardiac proteins that have a structural role. And in healthy individuals, most cardiac troponin is bound to sarcomere, with the remainder existing freely in the cytoplasm with cardiac myocytes. But with ischemic heart disease, which is largely understood in adults, and with the stress, cardiac troponin is detectable in the circulation, and particularly using the newer high-sensitivity cardiac troponin assays. Previously, actually, the original assays couldn't detect levels in healthy individuals, but the newer assays introduced in the last 5 years or so can easily detect levels in healthy individuals. But of course, in ischemic conditions, this level goes up significantly, and some of them are mentioned here. So there are clear indications in adults for use of cardiac troponin, particularly in adult myocardial infarction. Now, in adults, it is recommended that, and in clinical measurement, clinical lab measurement, cardiac troponin is measured usually using high sensitivity assays currently, and the guidelines suggest that you should use assays that satisfy two major criteria. One is that it can measure the 99th percentile of upper limit of normal with a very low imprecision of less than 10%, and detect the biomarker concentration at or above the limit of detection in 50% of healthy individuals. As I mentioned, these assays can pick up levels in healthy individuals quite well. But in children and neonates and adolescents, information has been scarce. And so I'm going to review some of the information, some from our own lab, but also from others. Now, we actually, years ago, started looking at reference values for cardiac troponin in children. And this is a paper we published in Clinical Chemistry a few years ago, where we used the cardiac troponin I in this case. We have also done the same study. This is actually T. We have done the same study with cardiac troponin I, also published in Clinical Chemistry, where we found that unique cardiac troponin concentrations were observed when looking at children and neonates. Actually, some of the findings we had surprised a lot of the cardiologists. And I will show you the data, and this is one of the graphs. You can see that cardiac troponin is extremely high in neonates. These levels are healthy levels. They're not disease levels. They're actually normally very high at birth, largely because cardiac troponin is being released due to the cardiac tissue development and maturation. As you know, the heart of the neonate after birth is still premature and it's developing. So therefore, releasing a lot of cardiac troponin. This was not well appreciated by even some cardiologists. So they were actually doing studies in neonates not being aware of these very high levels in normal. They were using adult reference values for children, which of course is inappropriate. These levels are very high within the first year, particularly the first few months of life, but they normalize, as you can see, and then they tend to be close to detection limit until later on. And we actually found some adolescents with slightly elevated levels, but those are largely because of physical stress, physical exercise. Some are, for example, marathon runners, and so on. You can have higher levels. Now, we did the same study. That was cardiac troponin T initially, and the same study in cardiac troponin I sees the same thing, same observation, whether you look at cardiac troponin I or troponin T. When you look at other cardiac markers like BNPs, as well as NT-ProBNP, there is also a lot of good information in adults, but not so much in children. So BNPs are, as you know, released from the cardiac ventricles in response to stress, pressure overload, and ventricular wall stretch. And for that reason, during heart failure, they tend to be significant increases in BNP levels. Particularly NT-ProBNP has become a very popular marker and actually favored by many, and commonly used to monitor patients in heart failure clinics. But we also looked at pediatric reference values for children through the caliper study that I presented yesterday. And if you look at this, you also see levels. This is levels that, this is actually a paper published very recently in collaboration with another group, looking at NT-ProBNP and BNP levels. And we also see elevated levels early, especially for NT-ProBNP, we see elevated levels in neonates, just like we saw with cardiac troponins. So therefore, you do require age and sex-specific reference intervals in some cases, particularly age-specific reference intervals. This is data also on, specifically on NT-ProBNP, seeing the same trend of very high levels early on that normalize. So actually, this was a key observation that 70% of the specimens collected from apparently healthy infants under 1 year actually had levels above the recommended cutoff. So that suggests that we do need to revise some of these cutoffs based on the latest information. But in terms of evidence for use of cardiac troponin, what is the evidence that we require these cardiac markers in children, hospitals, and pediatric lab service? This is part of our review article in Clinical Chemistry, and I want to just highlight some of the key areas that we described where cardiac troponin and NT-ProBNP particularly can be used. and are actually more and more used. Our own children's hospital is now heavily using some of these markers. We didn't used to offer these tests. We used to send them out to another hospital, but now we're performing both because the test volume is going up. So in the area of myocarditis, in the area of chest pain, actually there are some children with chest pain, although it's much less common, of course, than adults. Congenital heart disease actually relatively common in a children's hospital, especially tertiary care hospital like ours. And after cardiac surgery, monitoring children and there's a lot of cardiac surgery in children to correct heart defects and other congenital abnormalities. So using cardiac troponin and NT-ProBNP has become fairly common. And heart failure also, we actually have a pediatric heart failure in our hospital, and therefore the use of NT-ProBNP in that hospital. Now in myocarditis, so I'm going to review each of these areas in some detail. So myocarditis is an inflammatory disease of the heart, and is actually the diagnosis of this and prognosis is a challenge for cardiologists. And cardiac troponin measurements have shown to have clinical value in excluding children with myocarditis. And there are several diagnostic cutoffs that have been proposed for cardiac troponin. So proposed cutoffs tend to be much lower than those used in adults. And I've shown here one of the studies looking at this. And BNP and NT-ProBNP, however, have not demonstrated value in this particular myocarditis condition. But cardiac troponins, for sure, have shown value, and the data is shown here. As you can see, there's quite a bit of specificity and sensitivity using these markers. Now, in the case of heart failure, I'm going quickly because of time. In the case of heart failure, most pediatric patients with new onset heart failure are diagnosed late in the disease pathogenesis. But if one uses actually the cardiac markers like NT-ProBNP and BNP, you can actually diagnose the condition earlier. So studies suggest that the BNP concentration of more than 140 nanogram per liter in pediatric outpatients with symptomatic heart failure can identify children at higher risk of worse outcome. And this cutoff is substantially higher than the adult recommendation, which is actually 50. So again, you can see that you do require a specific attention to pediatric patients, and the cutoffs you use do need to be appropriate to the population, the pediatric population. So do pediatric guidelines support biomarker measurements? Clearly, they are, and measurement is strongly recommended in the evaluation of acute heart failure in children. Another area is CHD, coronary heart disease. Well, congenital, and actually in this case, not coronary, but congenital heart disease, is the most common form of congenital anomaly worldwide. I mentioned that there is a lot of cardiac surgery that happens in children's hospital because of these congenital abnormalities. And they're associated with significant morbidity, such as cyanosis, pulmonary hypertension. So therefore, they need to be corrected quickly and for the child to survive. Therefore, cardiac surgery is essential in these cases. And then using cardiac markers to monitor these patients after surgery in terms of recovery to prognose recovery has been very popular. So biomarker utility, as shown here, has been quite popular and increasingly popular, especially with troponin and NT-ProBNP. Cardiac surgery for other cases have been shown, and there are several studies, this is one of them, showing significant value. So predicting post-operative outcomes in pediatrics cardiac surgery is key in reducing adverse events, hospital stays, and the need for reoperation. So therefore, measuring cardiac markers in children has been shown to be very helpful. And further studies, though, are needed to characterize the appropriate cutoffs that are helpful in the prognosis of patients after surgery. In the emergency department, there are indications that, we actually have cases of heart attacks in children, especially those with, for example, familiar hypercholesterolemia, the homozygous form. And so myocarditis in addition to myocarditis, you can also actually have children presenting with chest pain. Other indications are shown in a recent study. Increased cardiac troponin T was observed in 9% of the study population, and a cardiac diagnosis was made in 60% of those with myocarditis, cardiomyopathy, arrhythmia. And serial measurements are probably even better, but they were not reported in this case. This is actually a fairly recent study in the American Heart Association journal. So in terms of secondary diseases, we also discuss in this review the importance of secondary conditions that can be monitored using cardiac markers. Again, a lot more detail is in the review article. It's almost a 10-page review article, so there's a lot more details there. But I'm just going to quickly, in terms of, for example, infectious disease-induced immune conditions and rheumatic disease, well, these markers can be very useful. So cardiac dysfunction, sorry about that. Cardiac dysfunction is a common feature of actually immune conditions induced by infection. We actually recently in the COVID, during the last 2 years, we actually have been using cardiac troponin to monitor children with COVID-19 infection. And as you know, the children develop this condition called MIS-C, multi-inflammatory sort of syndrome of childhood. This MIS-C was quite common actually, and we had quite a few patients admitted to the hospital. When we measured cardiac troponin, their troponin levels were quite significantly increased due to the COVID-19 infection. So that's just, this is shown here as MIS-C. But this is actually another study, but our own study in our own children's hospital supports what these papers have found. Other conditions such as sepsis, Kawasaki disease, and others can also cause significant elevations in these markers. Cardiotoxicity. As you know, many drugs actually can cause cardiotoxicity. So when you are trying to monitor cardiotoxicity, that's another area where you could be using these markers to monitor cardiac damage. And so I don't want to go over time too much, so you can look at the data in the paper, but there is a lot of good applications here. And actually, cardiac damage is pretty common, especially with overdose conditions that can occur, especially if you cannot have TDM, if you cannot have therapeutic drug monitoring, and it's not available for all drugs, you could have potential cases of overdose and toxicity. Well, in summary, this is, I believe, my last slide. There is a lot more to learn about the use of cardiac markers in pediatrics and children's hospitals, but we definitely there is a significant need for more research by labs working with cardiologists to establish evidence-based cutoffs and usage guidelines for different pediatric applications of cardiac troponins, and optimizing utilization and standardizing interpretation of cardiac markers. Thank you very much.